Good afternoon and welcome to the NDARC weekly webinar. I'm Professor Shane Dark, and today we're broadcasting from the ballrooms of Mercury because we are trying to find a planet that's warmer than the ones we've been on. And I hope you've noticed the difference. Now, while we're widely dispersed, we acknowledge traditional owners of country throughout Australia, recognise their continuing connection to land, waters and culture. We pay our respects to their elders, past, present and emerging. Now, I'm delighted to be hosting this week our speaker, Rosie Gilliver. Rosie's clinical nurse consultant at the Kirkton Road Centre in King's Cross. And for those of you who are unfamiliar with the KRC, it's a primary care facility in inner city Sydney that provides care to many of the most marginalised in our society. Has been doing so for the last 33 years. And I just want to put it on record that the work that Rosie and her colleagues have done over that period has been nothing short of magnificent and continues to be so. Now, today, Rosie's going to be presenting an information session on naloxone and opioid overdose. Overdose is one of the major public health issues that we face really across the world. And naloxone, or Narcan as it's sometimes referred, is the antidote, for want of a better word. Now, I should point out it's interesting, the history of this. People such as John Strang in the UK, Michael Farrell, myself and many others started arguing for its wide availability in the mid-1990s. And after a mere 25 years or so, it actually came on board, came online. Now, in this session, Rosie's going to provide information on how to identify an opioid overdose, how to respond, and to talk about the new formulation, Nyxoid Naloxone, which is a nasal spray only recently out, which has the possibility to be a real game changer. And I'd just like to note that naloxone is, if you're thinking it's only relevant to heroin, that's not the case. It's relevant to all opioids, for instance, pharmaceutical opioids such as oxycodone. Now, I just need to put on record that this isn't a certified training session, but an information session. You can log on to questions on the Q&A function, which I'll relate to Rosie at the end of the presentation, not chat, please. And we may not be able to ask one of them, but I'll do my very best. So, Rosie, without any more palaver, it's over to you.
Thank you so much, Shane. It's a real privilege and pleasure to be asked to participate in the NDARC webinars. As Shane so kindly said, I work currently at the Kirkton Road Centre, which is a wonderful primary healthcare centre here in the heart of King's Cross, and we're part of South East Sydney Local Health District. We have been involved in reversing overdoses for opioids over the period that we've been open, which is 33 years now, and also in the latter 8 years in take-home naloxone. I'd really like to say at the beginning that I'm not training anyone today in take-home naloxone, though I will discuss that program because it's something that's very close to my heart and I'm very passionate about. But today's talk is primarily around responding to an opioid overdose, how you recognize that, and what we can do as first responders in that incident. Okay, hopefully everyone can hear me and the technology works. Here goes. So first of all, I'd just like to acknowledge that a lot of the slides and material I'm using today are part of the South East Sydney Local Health District Orphan project. Orphan stands for Opioid Overdose Response Take-Home Naloxone. And I had the pleasure and privilege to be part of the team with my colleagues at the Langton Centre, and MSIC, and Newer and the University of Sydney, which really has rolled out take-home naloxone in New South Wales. I've also got some training videos, some of which have been made by pharmaceutical companies within my presentation. So what are we going to do today? Just really to talk about what an opioid overdose is, what are the risk factors and why is it we're talking about that in our community? What to do if you come across that in your work or within a community setting, and some short demonstrations of how to use the naloxone that I'm discussing today. So opioid overdoses in Australia, it is a changing story. Sadly, it's getting worse rather than better. like many countries actually around the world. So it's really is a global issue for all of us. Opioid-related deaths are steadily increasing, and they have done over the past 17 years. And it's accidental opioid overdoses which are the main cause of death. And we do know that 70% of opioid overdoses involve prescription opioids. So we think very much about, I guess a lot of the clients I work with here are injecting heroin, but in fact it's prescription opioids which are really the game changer in this increase. And sadly, 3 Australians die each day from an opioid-related overdose. It's a terrible statistic. In 2016, who was it that was the average person in this category? And it was actually a male in their 40s, often using prescription opioids and other drugs such as benzodiazepine, alcohol, and death was most often accidental. And your chance of death increased if you were living in a regional area outside of cities. And I think we can all acknowledge that access to health services, take-home naloxone and things like that are much harder often in regional and rural areas, which may play a part in the statistic. You can see a graph there on the left-hand side, and that indicates some of the main drugs involved in these drug-induced deaths by opioid type. We've got green, the oxycodone. As you may all know, OxyContin was very commonly crushed and injected, and the formula changed back in 2016. You can see that drop there. It's continued to drop. We have the red is heroin, methadone in the pinky purple, and then fentanyl there in the orange, which we've seen this increase in. People often think naloxone doesn't help in reversal of fentanyl, and that's not true. It can help reverse the effect of a fentanyl overdose, so it's very important to remember. So this is a little bit of work we did in the very first Orphan project back in 2019. We looked at those results. This was a very random group of clients that we had on our study. They hadn't been targeted. And in that, we collated this data, which was 86% of the clients involved in the take-home naloxone program had witnessed an overdose in their lifetime. So a really high statistic there. And of those, 26% had witnessed an overdose in the past 3 months. And when we asked them about experiencing an overdose themselves, 61% of clients reported at least one overdose in their lifetime. 30% reported 4 or more overdoses in their lifetime, and 6% had overdosed in the last 3 months. I think it's really worth saying that collecting this data is very difficult. The reason being is often people may overdose and not actually realize that that even happened to them. They may fall unconscious and wake themselves at a later time and not realize that they actually were in overdose for that period of time. They were obviously very lucky to come out of it themselves without any intervention. So when we ask this of clients, often they are remembering times when an ambulance was called or there was some sort of medical intervention. So one could presume that the statistics are actually probably much higher, but they may not realize that at times they are actually overdosing or even witnessing overdoses themselves. So we do have some really good evidence-based interventions that will reduce opioid overdose deaths. And there are 3, and they're recognized by the World Health Organization. The first being opioid substitution treatment. And I guess it makes sense to think if somebody is somewhat chaotically using opioids with no help around withdrawal and things like that, that being on a program where they're getting active. Sorry, you can hear police and ambulances. We are in the heart of King's Cross here. Being on a program where you're getting wraparound care and you want a nice steady dose of opioid substitution can actually lessen that chance of death. And I would like to say that there's a slight caveat with that, which is in the first 2 weeks of starting an opioid substitution treatment program, you're actually at an increased risk of overdose. And so we've done a lot of work for clients that are starting on any of these programs, especially if they're using methadone, that they should be given take-home naloxone and shown how to use it especially during that very early days of treatment. The second, of course, are the supervised injecting rooms. I'm really privileged to be able to look down the road. I'm looking out the window now. I can almost see the medically supervised injecting centre here at King's Cross. It's the most amazing organisation. It saves lives every single day. They're yet to lose any of their clients to overdose, and we need more of those rooms. We're very fortunate here. Obviously, if you're living again in a rural or regional area of New South Wales or Australia or in another country, you won't have access to that. And obviously, as most of you know, Melbourne's supervised injecting room started last year with the hope to increase it to a second injecting centre in the future. And the third are the orphan programs. So that's the opioid overdose take-home naloxone programs. And that is where we teach our clients that we work with, or our consumers, or our patients, whatever name you choose, who we know are likely to either have an opioid overdose or witness an opioid overdose, in how to use and administer naloxone, and we give them naloxone to take home with them on that day. And that's been an incredibly successful program here at the Curtin Road Centre, with most of our clients who are in that category having naloxone on them or in their homes, and with them at all times, so that they can successfully reverse opioid overdose. And indeed, many of our clients have done that. It's a fantastic thing to be able to be part of. So what is an opioid overdose? Well, really, it's, you know, taking more opioid on board than the body can handle. The opioid class of drug depresses the respiratory system, which is so dangerous as it slows down your breathing, that becomes more shallow and often labored, and then can potentially stop altogether. We often describe people in the state when they're very slowly going into opioid overdose as going on the nod. And you may have worked with clients and seen this firsthand, where people would start to become drowsy. They look like they're sleeping, which is the big mistake people make. They are not sleeping, they're having reduced consciousness. Often their head can fall forward, which often occludes their airway even more, which in turn reduces their respiratory rate further. Or it could be very rapid, so someone may inject and drop within seconds and minutes. It can happen in both cases. Often they will, skin will change color due to the lack of oxygen, and in some cases they may have a seizure. It's less common though. Unfortunately, once the respiratory system is depressed and stops, the heart may then stop, leading to the fatal overdose. So what are the risk factors for opioid overdoses? Well, certainly we know polysubstance use is a really significant risk. Even when I first started working here, people tended to have their drug of choice, which used to be heroin, or I take methamphetamine, but we do find increasingly so polysubstance use amongst our clients. And that also, I would say there's an increase in alcohol use also within our clients. And certainly when I've gone to regional areas and rural areas in New South Wales, people have talked about a higher level of alcohol use as well. So the biggest risks, I would say, in my experience, is the mixture of alcohol and benzos with opioids. As I'm sure you know, alcohol and benzodiazepines also reduce the respiratory system, sedating drugs, along with tricyclic antidepressants and antipsychotics. And certainly we see clients here all the time that are on this incredible cocktail of both prescribed medications and also street drugs, which they buy and sell on the street, which may not have been prescribed for them. And it's a very lethal combination often. Talking to clients and educating clients about these risks is incredibly important, and in itself can save a life. I really do encourage people not to assume knowledge. You know, we work with clients who have been injecting for 30+ years, and I'm still surprised about sometimes how the knowledge can be mistaken or just not there at all. So don't assume anything. Having a conversation about this is fantastic with clients. Other risk factors are this reduced tolerance. So using again after a period of reduced tolerance is obviously very risky. So I've got 3 examples of this, and I'm sure there's more, but they'd be the 3 ones that come to mind for me. Hospital discharge. So we do know, obviously, that people may be using once in hospital, but if you're in a hospital for a longer period of time, your use may either have ceased or gone down rapidly. And tolerance can reduce really quite rapidly, within days, in fact. And discharging from hospital, whether you're self-discharging because you're feeling you need to get out there because you're opioid dependent, for example, or you've been discharged with no care around your drug use, people will use straight away, and that's a really high risk time. As we'll see later on, if you've got an illness on board, so you've got infection such as a chest infection, foot infection, or dental infection, abscesses related to drugs, injecting, that also will increase your risk. So that discharge, if you've got one of those related infections, will doubly increase your risk. Being in a drug-free treatment environment, so the clients who are going to detox and rehab, as we know, you know, it's unusual to go into one detox and rehab and come out and never use again. Often it takes multiple admissions in these sorts of facilities. And when you come out, your tolerance is often very low. There is the added aspect of stigma and discrimination, shame. If you've gone into a rehab for 6 months and everyone thinks you've done this amazing job and you're not injecting anymore, often you will inject in a clandestine way where no one knows, in a different environment, and your risk goes up. So sadly, that also is a high risk. And again, we're encouraging many NGOs and drug treatment programs to be able to provide naloxone on discharge from those facilities. And incarceration. Of course, injecting drug use happens in prisons, we know that, but again, the substance will not probably be as strong, it'll be shared amongst many people, and the purity, as I said, will be lower. So when you come out of incarceration and start to inject again, sometimes in an unfamiliar place, your risk increases. And we're very lucky here in New South Wales, the program has just started that people being released from jail can be released with naloxone, which has been a fantastic move in the right direction. So the first time someone injects, I guess, or if they change routes, so they've normally been smoking and they change to injecting, can be a lot higher risk. And as we've taught, this greater purity. So just occasionally around the King's Cross, we might get a phone call from my colleague at MSIC who'll say, we've had a lot of drops tonight. We think there's some high purity heroin on the streets. Doesn't happen often, but it does occasionally happen. And if you're moving to a different place, so if I arrive in a different environment, I have to find a new dealer, I'm on my own. Again, all those things come into play around increasing my risk of overdose. And as mentioned before, having health problems, especially a major infection or respiratory disease, where you have lower saturation rates, oxygen saturation rates, or liver disease increases your risk of opioid overdose. So what is naloxone? Naloxone is a fantastic drug medication. It's a short-acting opioid antagonist. It has a peak duration of action of around 5 to 20 minutes and a half-life of around 30 to 60 minutes. It can't really do anything else, therefore it's a very safe medication. If you mistakenly give it to somebody who had a heart attack or a cardiovascular accident, you're not going to do them any harm. The only thing that it will do is antagonize opioids. We're all under the Act of the Good Samaritan legislation. If in the community we did administer naloxone and it wasn't needed, we will be covered by the Act, which means that no one can take us to court because we were acting in what we felt was the best interest of that person. And it's an S3 drug now, so it's available over the pharmacy. You can buy it, and some pharmacies now belong to a scheme, a Commonwealth scheme, where they can give it out for free, which is a fantastic, another step in the right direction. So how does naloxone work? This is a great slide to illustrate this. So we can see when the opioid is injected, it crosses the blood-brain barrier and it goes to the receptors in the brain. It attaches to those receptors, which are the little red balls that we can see, and they fix very fast. When we inject or we dispense naloxone intranasally, it follows the same pathways and it goes to the same receptors. It knocks off the opioid and it attaches. So it attaches for that time frame of around 20 minutes, sometimes longer. And whilst it's attached, the opioid can't reattach to those receptors. And what we're hoping in that time is that the respiratory system starts to work again. That's the idea, and it really works. For all of those that have administered naloxone, it's incredibly rapid. It's a bit of a miracle drug, really. The issue, of course, is that when the naloxone wears off, which will happen in that 30 to 45 minute time frame, if there are still opioids in the circulating, they will reattach, which means that somebody could potentially overdose again, even without taking more opioid on board. And that can be the problem with some of the longer lasting or long acting opioids, such as methadone, for example. So we have two main naloxones which we are using currently in Australia. And these come in two different formulation types. We have Pranoxad. So as you can see, Pranoxad is an injectable. It is in a pre-filled syringe. It has 5 doses within that syringe of 4 milligrams or 0.4 milligrams or 4 micrograms of naloxone. Is in a little box, and I'll show you a video a bit later of how to use that. It comes with 2 needles, which you attach, and you deliver a little bit like an EpiPen. You dispense the plunger to the first line, and you do this for every 2 to 3 minutes until a response occurs. The other, which is, as Sean was talking about, the new kid on the block, which is really transforming, I guess, the way that we see naloxone, because so many people have an aversion, quite understandably, to using needles and are concerned about things like Sharp's risk, is this very user-friendly naloxone nasal spray, this intranasal administration of naloxone, and it's called Nyxoid. It's produced by Mundi Pharma, and it was licensed in Australia last year in 2019. It comes in a box, and in each box you have 2 applications, and one application is for one use only. And it contains 1.8 milligrams of naloxone, and that's the equivalent of the 0.4 milligrams in each dose in the injectable. It's administered by inserting it into the nasal passage and pressing the applicator down. And again, if there's no response, you take the next Nyxoid out of the box and you repeat again. So how do I know when I come across somebody who has got an opioid overdose on board? What are the sorts of things that I'm looking for? Certainly the first sorts of things are lowered consciousness and not responding to verbal or physical stimulation. You know, people used to say, oh, you just give them a slap around the face, and we don't need to do any of that sort of thing. It really is physical assault. When somebody is in this state, I would give them a gentle shake of the shoulder, and especially if I know their name, I will try and call their name in a loud voice. People will often respond to verbal stimuli, and they may wake up and be able to have a conversation with you for a while. At that point, I'd just keep talking. But if they rapidly became drowsy and slipped into unconsciousness again, I'd be really concerned at that stage. And at that stage, I'm wanting to act if they're unable to maintain consciousness enough to have a conversation with me or to talk or respond to me verbally. Other signs may be this lack of oxygen around the body, leading to a pallid looking of the skin, blue lips, cold hands and cool pale skin. And obviously you're starting to see this impaired respiratory function. So breathing becomes infrequent. Snoring is a really marked thing to look for. Snoring is sleep apnea, so it's the body not getting enough oxygen in. So when people snore, their body is trying to increase the oxygen going into their body. And there's some posters around from Neuro, and they used to have one at MSIC, I'm not sure if it's still there. It says, don't ignore the snore. It's really important not to think, oh, they're snoring, they're having a great sleep, because that's not what's going on for that person. And of course, pinned pupils. So when people are using methamphetamines, you're having this diluted pupil, and with opioids, you're having this really constricted pupil. In my opinion, though, I really am just going for looking at that consciousness levels, looking at that verbal response, and looking at the breathing. So they're the two indicators that I would normally look for, definitely. If you're not getting a verbal response, it's time to act. And the first thing that we always do is call the ambulance. So we go back to this sort of the danger ABC, I guess, which we've all learned about in our first aid course. So responding to any sort of emergency situation, you're just being aware of danger. Is it safe to approach somebody? Is the environment safe to go into? If you feel unable to approach somebody, or you can see a body at the end of a little alleyway, but you just don't feel it's safe to go in, or somebody tells you there's someone in a house, but you don't want to go in for obvious reasons, what you do is call the ambulance in that case. You never put yourself in any harm's way or anywhere that you feel may be dangerous. You don't want two casualties to look after. So just make sure the environment's safe to approach. And in our situation here in clinic, when we're dealing with overdose opioids, that would be, are there any needles around? So I'm not going to go in and kneel down and kneel onto a needle. So just be a little aware. If somebody's injecting, there probably is injecting equipment around. Is this an overdose? So is that person responding to their name, to a gentle squeeze of the shoulder? What is their breathing like, their skin and their pupils? Yes, I think it's an overdose. In a community setting, in your clinical setting, it may be different, and everyone will have a different policy and protocol around that. But in a clinical in a community setting, at that point, you will be calling for help. So you'll be calling 000. There is some contention. Would you administer naloxone before calling 000 to get emergency response, or whatever that is for you, and whatever that number is? But we do encourage people to phone first. The reason being is that you will be given support over the phone. When the adrenaline's going and you're feeling nervous and you're not quite sure what to do, that can be really helpful and supportive to have someone talk you through what you should do. Next, you want to administer naloxone. So you get your naloxone out, whether that's the injectable or the Nyxoid spray, and you open the packet. With the intramuscular, you're going to attach the needle, or just open the packet with the intranasal. You then use the naloxone. You'll be able to see here on my slide, we've got 5 airways and rescue breathing. Again, very contentious in this time of COVID. We probably wouldn't be doing that now for obvious reasons. And really, if you go back to your basic CPR and first aid, we're not encouraging people to do rescue breathing. You often, if somebody is completely stopped breathing, you're just going to be going to chest compressions during that time. In my experience with a lot of the clients that I have for first opioid overdoses with, they normally are still breathing, but it's very shallow. We're very lucky here. Obviously, we have oxygen, which we can apply. You haven't got that in the community. So you administer your naloxone. You wait for these 2 to 3 minutes. Can feel like a lifetime, but it's important to give that naloxone a chance to work. If there's no response, you repeat and administer your second dose of naloxone. And you stay with that person until the ambulance arrives. Sometimes people will get up very, very rapidly, and they may just walk off. They are unwilling to stay for the ambulance to arrive, for them to get checked out. There's nothing you can do about that. And so the paramedics are normally fine. And I've often said, look, there's somebody walking down that road. They're unable, you know, I'm worried about them, and they may drive along and see if they can find them. If the person is still there, the paramedics will check them out. They won't necessarily take them to hospital, but they'll, again, look at their consciousness levels and make that assessment. So I've got 2 little movies just to finish off with. They both demonstrate what to do in case of overdose. The first is how to use the Prenoxad, and the second is the Nyxoid. With the Nyxoid, a question that a lot of the clients I work with say is that, well, if someone stopped breathing, how do they inhale the Nyxoid? And I think it's a good question, but of course it's an intranasal product. So somebody doesn't have to be breathing to inhale. It goes into the little capillaries in the nose, and that's how it works. That's a question that's often asked. So I'm going to really hope that this works, and it's in my the gods of webinars are shining on me. So bear with me here.
To use Prenoxad injection, remove the wrapper using the tear strip. Twist the outer plastic box to break the seals and open. Take out the Prenoxad injection syringe and one of the blue needle packets. 2 are supplied in case one is damaged or becomes contaminated, for example by being dropped on the floor. Peel back the backing paper from the needle packet and remove the needle, keeping it in its protective sheath. Unscrew the clear plastic top from the syringe. With the needle still in its sheath, screw the blue fitting onto the syringe. Holding the needle on the syringe with your thumbnail, gently twist the sheath and remove it. Twisting the needle sheath instead of pulling it avoids needle stick injury. Holding the syringe like a pen or dart, insert the needle at right angles into the outer thigh or upper arm muscle, through clothing if necessary, and inject to the first black line to give a 0.4 milliliter dose. Withdraw the needle and put the syringe with the needle still attached back into the cradle of the Prenoxad injection case. If you need to give another dose, insert the syringe again near or around the same site and inject to the next black line. After using Prenoxad injection, keep the syringe in the box and hand it to the ambulance crew so that they know it's been administered.
Okay, so that was how to inject Prenoxad. It's incredibly easy. And even though it is an injectable, if you find somebody and they have got Prenoxad on them, because a lot of people have Prenoxad with take-home naloxone, that was the first naloxone we used, that's how you do it. Attach the needle straight through clothing, a bit like an EpiPen. Don't be scared, that person won't feel anything. It's important to say that, and it works really well. So this is the intranasal naloxone. This video is produced by Mundi Pharma, which is the pharmaceutical company that produces Nyxoid. It's got some very cheesy music, and there is a longer version of this, which is their newer information, which I've given the link to at the end, but it's a little bit long to play today. So this was the very first video that they made when it first came out. Whoops. Here we go. the two little videos. I've put here just a couple of links, and I know NDUC are going to put this up on their website. I'd really encourage anybody who works with clients who are at risk of witnessing an opioid overdose or themselves experiencing to also further investigate training to be a take-home naloxone provider. We all are here at Curtin Road Centre. I think it's one of the most satisfying things that we do in many ways to try and advocate for that and enable people to have that as part of their harm minimization, harm reduction framework and toolkit here. So that's me. I'm going to go back to Shane. I'm happy to answer any questions you have.
Great, outstanding, Rosie, as always. Look, I've got a question here from Eduardo, which can naloxone be administered IV, and would there be any pros or contras to IV administration?
Yes, that's a question that I'm often asked, and the answer is we don't administer IV. I often have to talk a lot to my clients around this because they immediately always think about IV intravenous when it comes to injecting, but it really works incredibly well in the muscle. That's the way it's formulated. It's formulated as an intramuscular injection, and it's a much safer way to administer it. So there is no need to find veins. As we know, those of us working with clients who inject, venous access is always very difficult anyway. Yeah. You'll be messing around trying to find a vein, totally unnecessary, straight into the muscle. It works really rapidly. Yes.
That's a very important point.
Yes.
Just to, Eduardo also asked, and I think he's referring to buprenorphine here, but do we also use agonist opioids combined with naloxone? So naloxone is making an appearance in buprenorphine.
Yes, absolutely, in the form of often naltrexone, which obviously makes it safe. So it does provide some protection, absolutely. But, you know, you don't know what anybody's on or what anyone's taking. Yeah. So any of our clients, and we have clients here, Curtin Road Centre on Buvidal and buprenorphine, we would always give them naloxone to take away as well. Yes.
Yeah. There's a question here from Ria, which I think is a pertinent question, which is, and I think we alluded to it earlier, with so many opioid overdoses involving pharmaceutical opioids, yes, should naloxone or overdose education be basically co-prescribed for people being prescribed pharmaceutical opioid, who may have nothing to do with illicit opioid use ever?
Well, in my opinion, yes. And I know there's been some great work by, especially a couple of the clinicians at the Langton Centre talking to GPs around this very issue, that if you are prescribing any opioid analgesia, you really should be having this conversation with your patients and potentially dispensing it in the same way with the opioids. Absolutely. Yes, is my answer. I don't know if I've got that much sway, but you know, we really are trying to make big headway in this. One of the things that's happening, which is lovely here, for example, at St. Vincent's, here in the King's Cross, when somebody comes in with an opioid overdose, when someone's discharged, they're discharged with naloxone, which is you know, yeah, in the right direction.
I think so. Now, one thing to keep in mind is for chronic pain patients,
absolutely,
they're quite often co-prescribed diazepam for back spasm.
Totally. We're seeing a lot of Lyrica being used and things like that. They all contribute to overdose.
Yes, indeed. Question, another one. Well, there's a couple of questions on the actual event, but Ria's asking, the EpiPens have quite a short expiry. What we're talking about with naloxone,
it's similar. It's around
12 months or?
Yeah, 12 to 18 months. We would say to anyone, if your medication's expired, just use it anyway. It probably will still work. We know that they often, you know, survive way beyond that expiry date. But if it has expired, just go back to wherever you got it from, chemist, your clinic, and get some more. Yeah.
Yeah, no, I think it's important to keep
But use it. If you've got it and it's expired, still use it. It may work. It's not going to do any harm. Yeah.
No. Regarding that, sorry, this screen's jumping around. When injecting naloxone, does it matter if you give more than give more than you intended? If they went 2 points, will they go into more serious withdrawal or?
Look, the reality is, if you're going to give more, you probably are pushing someone into a quicker response. And there is reasons that it's in small doses, and that's because somebody comes around it a lot more gently. Saying that, and that is one of the difficulties with that injectable. Your hands are shaking. You've got to look at the line. I need to find my glasses to put that on. It's very easy to give 2 doses instead of 1.
Yeah.
No, nothing bad is going to happen. That person will just wake up a little bit more quickly. They'll feel a bit shitty, really. That's the truth of it, as they wake up more quickly, but you won't harm them. And that's the beauty of the nasal spray, I guess. It's very easy to use. You don't have to worry about those things. Yeah.
Yeah. It's a remarkably safe drug.
It's remarkably safe.
Yeah.
Yeah.
We've got is the Good Samaritan Act in New South Wales, is that true in other jurisdictions?
That's a really good question. Each jurisdiction is slightly different. It's worth looking up. Some, if you're intoxicated, it won't necessarily cover you in some states. And there is one state where it isn't covered, and I can't off the top of my head remember if that's NT or Tasmania. I think it might be NT. So it's worth looking in your own state. And of course, we're talking about Australia. I do believe there's a few people from overseas that might be with us today, and I'm not sure about their own legislation. But I would argue it would be, I have never heard of anyone prosecuted ever for administering naloxone to anybody in an opioid overdose. I think it would be incredibly rare. Do not worry.
Wayne Hall saying in the 1990s, it's really like diabetes. I mean, no one's ever been prosecuted for saving a life.
No, absolutely. You know, please do not worry about that.
Yeah. But you mentioned overseas. We've got a question here from Nigeria, Olajumoke. I'm joining from Nigeria. Naloxone's not available there. Are there any other options to naloxone?
Well, wonderful. We've got people joining us from Nigeria. Isn't that fantastic? Yeah, it's wonderful. Oh, you know, I think the most important thing would be to get help. That's the first thing, and put someone in the recovery position. If you've got access to oxygen, use that. In the medically supervised injecting center, most opioid overdoses are reversed with oxygen therapy. You're just increasing that respiratory assistance until the opioid is worn off a bit. So if you're within a clinical context, you've got that option. If not, it's very, very difficult. I would say lobby for it. It's been a hard road here, and that's what we've done. But it's difficult. Yeah.
Can I just say it's a real pleasure to have someone from Nigeria watching today. Very, very welcome.
Lovely.
Very
yes.
welcome. This is a question, and this is something we dealt with in the 1990s. There's the argument, if you provide naloxone,
I know what you're going to say.
Encouraging risky use.
Yeah, I think it's a really important point.
Yeah, no, it is.
In the studies that we participated in the Orphan 1 and 2, what we found was, and our big worry was around calling ambulances.
Yeah.
If you gave somebody the naloxone, were they less likely to call an ambulance to help with? So that's a slightly different question, but of the same ilk, and it didn't. And we do know, when we've studied harm minimization in and out, providing clean needles, providing things like naloxone does not increase use and does not increase risky use at all. It just actually helps in those circumstances for people to be safer.
Well, people don't.
Good question.
No, it is a good question, and people don't like going into immediate withdrawal anyway.
No.
And ruining the stone, so to speak.
That's right.
A technical question: is there an issue of hitting a nerve when you're doing an IM?
No, don't worry about that. Just go straight in to the thigh or the deltoid muscle, straight in with the needle. No concerns around that. And also, the nerve you're worried about is in the bottom. So just avoid the buttock. Go into either the deltoid muscle here or into your thigh, and you'll be safe. Yeah.
Some very, very fine questions here.
Yes, excellent. I'm being tough. It's like hopefully I can answer them all.
Oh, you're on top of it all, don't you worry. Does it matter which nostril you spray the second one into?
If you can see somebody's obviously got some damage to a septum or something like that, just from the way that they're looking, avoid that nasal passage. Use one. If they don't wake up with that first one, I would tend to use the second one for the next dose if they need it. And that way you think, well, if it didn't work the first time, perhaps there was some blockage, I'll go into the next nose, the next nasal passage. But it doesn't matter. No. I need to push it, just push it in. And don't worry, that person can't feel. They're in an opioid overdose. So they're not feeling any of these interventions. Obviously, you need to be kind and treat someone with respect and care, but they're not going to feel the injection. They're not going to feel it being pushed into their nasal cavity.
A couple of questions. Carfentanil. You sort of referred to the broader thing of fentanyl. Could it be used successfully if someone's taken carfentanil?
Carfentanil is incredibly strong. You know, the chance of reversing that, I don't know what the statistics are, but luckily we are hardly seeing that in Australia. So we've been very lucky around that. What I would say, and I think Sean, you and I talked about this earlier, you've got nothing else. So use it anyway. You just need to use it and try, because that's what you've got, and call that ambulance first, especially in a regional area. It's going to take a long time for that ambulance to get there. So call and use what you've got at your availability. You will not harm, and it may help slightly. But it's very, I want to acknowledge it's a very strong drug, very strong indeed.
Yes, it's one we hope doesn't get out of the box.
Absolutely. We're hardly ever seeing it here though, to my knowledge.
Just a couple of questions have asked the same thing basically. Do people get agitated and angry with the person who does it, who administers?
That's a really good question. It's something people are very fearful about and don't want to intervene because they're worried about what's going to happen afterwards. In my experience, which I can really only talk about, it's been very rare. Most people aren't like that. And one of the reasons being is you're giving this small amount and people come around quite gently. For a lot of people, though, I need to acknowledge that if you're opioid dependent, you know, you will go into a withdrawal and you will have to probably find some opioids later on in order to stop that withdrawal from occurring. So it's important to have a conversation that they're really at high risk of overdosing again, even without having more drugs on board, but certainly if they inject again, and to try and go somewhere safe if they're going to use again later on. Most people, though, are just slightly confused, really, and can't remember what had happened. That's normally the response.
I mean, there's an attendee saying, well, then should you give them diazepam or antipsychotics to calm them down? But no. Absolutely not. You know, you're just increasing a cocktail potentially if, you know, and look, unless you're a doctor, you're not going to be able to get hold of those things. You know, I really wouldn't recommend anything like that at all. People just need to sit, you know, just to be in a gentle, calm space and to figure out what's going on. Adding other medications in is not the answer. We spoke briefly, Rosie. I won't keep you for too much longer. You're doing
That's okay. That's okay. I'm really happy to stay.
It's just an expression of how much interest there is. But we spoke briefly about naloxone before in relationship with buprenorphine, Subutex, for example, or Suboxone. I can never remember which is which. But could you use Suboxone, or could you use the combination antagonist and agonist in a situation, and would it have any effect injecting them with buprenorphine and?
I think you sort of, I do really understand the question, but I think it's over complicating an issue, to be honest. You know, we have here at Cote we have a drop box, and in that we have our naloxone. We don't know what that person's got on board. We have no idea often, and you know, you just need to respond with what you know is going to work best, and that's naloxone. So just go straight for naloxone, call the paramedics, let them do that job, and take over. You
don't want to add any other polypharmacy.
Absolutely not. Absolutely not.
Yeah. I think it was a very interesting question.
Yeah, absolutely.
We've got a question from Kevin Chang. I think we've already answered that. Should we prescribe it for patients on high doses of potentadol or tramadol, so other opioids? I think your view is that yes, we should.
Yes, and I mean, you know, you don't even need to prescribe to a certain extent. We have great relationships with a couple of our community pharmacies here. If you encourage them here in Australia, we're very lucky in New South Wales to sign up to the Pharmacy Guild's program. They can give out free naloxone to clients, which is fantastic. But they can certainly prescribe. If someone's got a healthcare card, it will only be the $6.20 in New South Wales to get that at a chemist. And friends and family as well. We often get friends and family, and that's where the nasal spray comes in. If you've got friends or family that are injectors you're concerned about, you can have some nasal spray at home for those situations.
And particularly for people who've never injected anybody.
Totally, because it's frightening giving an injection when you've never done that before.
Whereas everyone's probably put a spray up their own nose for
Totally, don't prime it. That's the only thing. Don't prime it.
Okay.
Yeah.
How do we convince people who are how do you basically convince, say, methadone clients or bupe clients to convince them to take home some? They might think, I'm stable, I'm not at risk. Do you have any trouble convincing people to do that?
There's a couple of my clients that are serial objectors, I'd say, but you know, I think it's building a rapport, talking about naloxone in a very unstigmatized, sensitive way, and really flooding the market. You know, you just having broad education, information, sessions on it, and just getting it out there. And certainly some people will choose not to take it, and that's their right, absolutely. But just you know, just that's okay, and you can keep occasionally asking, and and I'm a naloxone pusher, I'm afraid.
I doubt you'll do much jail time for that. I think this is an interesting question on how would you treat a client who's been on home detention, who is at risk of OD of multiple drugs and released from home detention. So this is the issue of the person who's in that high risk period when they've been.
And this is why we want to get more people. So any services, the wrap-round services that may have some interaction with a client like that, parole officers, when they've, you know, anybody who can encourage and inform that, hey, we've got this naloxone, but it has to be done in a way, because obviously people don't want to out themselves that I'm still injecting and I might be at risk. So it's giving clients the ability to either get it themselves from a community pharmacy, or for services to, in a very non-judgmental way, provide it to all clients. And just to be aware and acknowledge that people do inject drugs, and they are going to, and just making sure that their safety is of the most importance.
This is I'll be wrapping up. I just asked this one last question. So basically this goes back to, I think alludes to something you said about not doing harm. If you suspect overdose and smell alcohol, which is not atypical,
no,
and maybe they're actually drunk, will the spray affect them or put them in any danger?
Yeah, it's a good question, and no, it won't. It won't do any harm at all. All it does, the only thing that naloxone does is that it is an opioid antagonist. It has no other function in the body. You could check the pupils and things like that. But yeah, if in doubt, you can use it with no fear of harm.
Yeah, you're not going into alcohol withdrawal or anything like a.
No,
It's an opioid,
absolutely. It won't have
specific
any
opioid.
effect on the alcohol, unfortunately. And that's the problem if you've got a lot of alcohol and benzodiazepam on board. Unfortunately, it won't have any effect on that. But it's still worth giving it a go.
Yeah. NSP, we just got a question, and then I'll wrap. Joe Lavaco has asked, is naloxone available by non-medical NSP providers? Certainly in New South Wales it is.
Totally. So we've just pushed out the take-home naloxone for people working in drug and alcohol settings who are non-clinicians in New South Wales. And now we're hoping in most of the districts here, the health districts, there are people that can provide take-home naloxone in those settings. And there is some new online training that's coming on. So I'd really encourage people to investigate that and sign up for it. And that's in NGOs and for people still working in health that can do an online trainer and become credentialed as take-home naloxone educators and suppliers.
Great. And just to finally actually wrap up, you mentioned this, but you're getting such good questions. Is there a particular way of spraying up the nose? Do you need to go deep into the nasal cavity?
I would push as far as you can. Yeah. And at that point you dispense. When you dispense the nasal spray, you hear a click. You can hear a slight click. Okay. It's in at that point. Yeah. So right. Push in, you'll hear a click. You've done the job.
Brilliant. Look, we've got a number of comments just saying excellent amount of information and commentary. Thanks for a great talk. Excellent talk. I concur. It's been sensational, and you know, I think you can't possibly push naloxone enough. It's a lifesaver, and I think your information today is crucial because many people may find themselves in this situation.
Absolutely, absolutely.
So look, I wish you all the people out there, thank you very much, Rosie. I wish you and all of our audience, thank you for your attendance, and I wish you a wonderful evening or morning or afternoon, wherever it is in your particular time zone. So thank you, one, and thank you all, and thank you, Rosie.
Thank you.